Hi, welcome back to Student Nurses Success, where we are committed to helping you earn that A plus in your pathophysiology course and become that great nurse that you want to be. Today, our topic is altered immunity. This will include excessive immune responses and hypersensitivity reactions, as well as a very brief discussion of deficient immunity. So we'll cover both too much immunity response and not enough immune response. So let's begin with our maps. And remember, the link to where you can find our maps can be found in the comments section. And here we have our blank map. Now I've divided it into three columns just to kind of keep us on track and give me enough room to kind of write. The first thing we want to talk about is excessive immunity. Excessive immunity can be autoimmune or autoinflammatory, and these terms can be a little confusing. They kind of mean the same thing. They both mean there's too much immune response. It's out of proportion to what is necessary. But the immune responses fall into two different categories. Autoimmune diseases are kind of the adaptive system disorder. So it's when your adaptive immune system has kind of gone out of whack. It's when your body does not recognize itself and it sees itself as foreign and attacks its own tissues. Examples of this is lupus or SLE or rheumatoid arthritis, RA. Those are more common autoimmune disorders. Autoinflammatory disorders are disorders of the innate immune system, and that's what causes chronic inflammation. These aren't quite as common, but in these particular cases, it's when the innate immune system is kind of out of whack and causing too much of a response. Now, the etiology of excessive immune responses, a lot of times these are genetic disorders. We see them a little more commonly in females. We know that stress and environment can also play a role, but we don't always know what causes them. We're also going to talk about hypersensitivity disorders in part of our excessive immune system talk today. These hypersensitivity disorders include types 1, 2, 3, and 4 hypersensitivity reactions. Now remember, excessive immune responses or these hypersensitivity disorders are when there's inappropriate activation of the immune system. Let's start with our type 1 excessive immunity disorders. Type 1 is our classic allergic reaction. Our classic allergic reactions are IgE mediated disorders. They tend to run in families and they include allergies such as food allergies and bees. Those are probably some of the more common ones. But down here, you kind of see this picture of the peanut, the dreaded peanut allergy. Or sometimes it's a shrimp allergy, or it's a tree nut allergy. So in these particular cases, these are classic allergic reactions that can lead to anaphylaxis. There. Let's talk about the patho behind them. With type 1 classic allergic reactions, we know that the response is almost immediate. We actually will see the reaction in somewhere about 15 to 30 minutes. So these are pretty quick. What happens is exposure to the allergen or the antigen causes specific IgE production by the B cell. And we know that repeated exposures to these allergens or antigens increase IgE levels. So, what that means is that each time you are exposed, you run the risk of a more serious reaction. So that can be dangerous. So let's say you have a peanut allergy and it just causes a little bit of itching. The next time it actually could cause full-blown anaphylaxis. It may not, but it could. And so we do know that repeated exposures increase the reaction and the risk of anaphylaxis. Now, your mast cells are covered with these IgE receptors. And so what happens is when you're exposed to that antigen, you release histamine. And so histamine causes vascular permeability, which causes leaking of fluids and edema. So a lot of times we get something called angioedema. We get swollen mouth, swollen tongue, swollen airway. So that edema can be really dangerous. It can cause wheezing and bronchoconstriction. Okay, so that swelling narrows those airways. You're going to become tachycardic as a compensatory response. And you're also going to see massive vasodilation from the histamine. So, this histamine is really responsible for a lot of the symptoms that you see in type 1 classic allergic reactions. That vasodilation is going to drop your blood pressure and make you hypotensive. So the big risk here is anaphylaxis, okay, where you can't breathe and you get the typical maybe tongue swelling, um, uh, airway compromise. Often we see people have urticaria or itching, rash, okay, hypotension. Certainly, these are life-threatening, okay? And our response to that is epinephrine, okay? An EpiPen can help there. We recommend that you avoid what you are allergic to. And there's also some desensitization therapy that you can participate in, allergy shots, where they give you tiny, tiny, tiny doses of the antigen, and it's done in a very controlled environment of like a healthcare provider's office. And hopefully, you would become less sensitive over time. But this is not something you can do yourself. So you can't like take a teaspoon of peanut butter and do your own desensitization therapy. It's micro increases in the amount that we're exposing you to, and there's a risk involved with it. Now let's talk about type 2 immune reactions. Type 2 are tissue specific or cytotoxic. What we mean by this is that it causes complete destruction of cells. It's an IgG or IgM antibody that binds to the antigen and causes the lysis or the destruction of the cell. So the cell breaks open, releases its content, and the cell is destroyed. I mean, that's fine if it's one cell, but these are attacking many cells. Usually the response is pretty immediate, but it can actually be even up to a few weeks later. Examples of something that can cause a type 2 tissue specific cytotoxic reaction would be a blood transfusion reaction where we give the wrong type of blood to a patient. And so there is a reaction where they will actually kill off the blood cells and release all of that in the body, that trash when those cells are broken. Or a graft tissue rejection, perhaps maybe if there's a bone marrow or stem cell transplant that is not matched properly and the um, one of the either the graft or the host attacks those cells, or Rh incompatibility. You've heard of this, where perhaps mom is Rh negative and the baby is Rh positive. The mom will actually develop antibodies and kill off the baby's red blood cells. In those particular cases, we call that hemolytic disease of the newborn. And hemolytic means broken red blood cells. And babies with hemolytic disease of the newborn actually, when they're born, are very sick because they don't have enough red blood cells because they're being lysed and broken. In order to help manage this, we give RhoGAM at both 28 weeks pregnancy and at the delivery to prevent this reaction. Now, how do you know someone's having a type 2 tissue specific cytotoxic reaction? You will know. These are systemic responses, they're pretty immediate. Patients will be flushed, have chills, fever. They will decrease their urine output because it's very harmful to the kidneys. Their heart rate will increase as a compensatory mechanism. They will become hypotensive with a decreased blood pressure, and they can actually even go into shock or death. So these are very serious. And whenever we give blood to a patient, we always monitor for this. Our next is a type 3 reaction. This is an antigen antibody complex. In this particular case, it's IgG and IgM, but it is not a tissue specific problem, so there is no cell lysis. So the cells are not being broken. What's happening in this particular case is these antigen antibody complexes are not cleared. They're actually, when an antigen and an antibody connect together, it should clear that out. That's how the antibody attaches to the antigen and breaks it up and takes care of it. But in these particular cases, these antigen antibody complexes are not cleared and they remain together. So it's almost like a weak reaction. The problem is these antigen antibody complexes sit on the connective tissue and they smolder. They cause a chronic inflammatory low level inflammation that causes tissue swelling, inflammation, and scarring of the connective tissues. So it kind of activates this cascade of vascular permeability, edema, inflammation, and this chronic low level inflammatory response, which is damaging to the tissues. Examples of a type 3 include something called APSGN, which is acute post-streptococcal glomerular nephritis. Oh my goodness. Let me write that. That's a big one. Acute post-streptococcal glomerular nephritis. So with this, it is after a strep infection that has been either incompletely or not treated. And so those strep toxins kind of sit with these antigen antibody complexes and cause this reaction in the kidneys. And actually, that's where the glomerular nephritis is. Another example of a type 3 response is lupus or SLE. And we see this chronic inflammation damaging lots of tissues in the body for patients with lupus. And we'll talk about lupus here in a second. Rheumatoid arthritis or RA, and something called HSP, which is another reaction where you will actually see bleeding, bruising, and some kidney involvement. It's not terribly common. So with type 3 reactions, they are not immediate. They're chronic, they're ongoing, and in some cases, we see rashes and vasculitis or inflammation of the vessels as a complication of these diseases. So let's talk real briefly about lupus. Lupus falls under these type 3 reactions. And lupus is a chronic multi-system inflammatory autoimmune disease where you have overactive B cells causing this inflammation. We do know that it is genetic in nature. There seems to be some type of genetic component to it. We do see that patients with lupus have exacerbations and remissions of their disease. So it kind of comes and goes, that inflammation. More common in females, and somewhere about the age of 15 to 40 years, we see the onset. Patients with lupus have a lot of chronic fatigue from the chronic inflammation. We see a lot of kidney involvement with them, a lot because the kidney is the connective tissue of which you get this kind of chronic inflammatory response. And it actually can cause permanent kidney damage and require either transplant or dialysis. Patients with lupus, this inflammation occurs in their vascular system as well. And so we get vasculitis or inflammation of the vessels. And we see this very commonly as rashes or redness on their body, or a lot of them will have butterfly rash on their face when those vessels near the surface of their skin are inflamed and red. They have arthritis and arthralgias, chronic inflammation in those joints, which causes pain. Again, joints are connective tissue. They may have neuritis or even seizures, so they can get inflammation of their nervous system. They have inflammation of maybe their heart or their lungs. And in order to, how do you know you have lupus? A lot of it is related to symptoms, but they may have something called a positive anti-nuclear antibody test. They will see an increase in their sedimentation rate or their ESR, showing chronic inflammation. And a lot of them will start to see this decrease in kidney function because the kidney function is one of the hallmark symptoms. Let's move to our next category, and that is type 4 hypersensitivity reactions. Now, type 4 hypersensitivity reactions are called delayed hypersensitivity. These are cell mediated, but they have to do with the T cell. And remember, T cells kind of cycle up a little later. They're part of the adaptive immune response. With delayed hypersensitivity, you actually aren't going to see the results for 24 to 48, even 72 hours. So you could be exposed to the antigen, but you aren't going to see any symptoms for almost a day later. What we see with type 4 sensitivity reactions is an overreaction of the CD4 and the CD8 cells. And remember, the CD4s are the T helpers, and the CD8s are the T killers. And you see those guys cause chronic inflammation and mast cell degranulation. And that's where you're going to see the symptoms, but you're not going to see them for a day or two. And sometimes that's hard. So you're exposed to the antigen on Tuesday, but you aren't even going to see symptoms till maybe Wednesday or possibly even Thursday or Friday. And you've probably forgotten what you were exposed to 2 days prior. So sometimes it's a little hard to iron these out. Usually, what we see is contact dermatitis or skin rashes. Um, Happen a lot. So, common causes or common examples of delayed hypersensitivity, poison ivy is one. So, if you are allergic to poison ivy and you touch poison ivy, you're not actually going to see the results for a couple days. We also know that some latex allergies are type 4, nickel allergies. Some people are allergic to the metal nickel, or some people are very sensitive to maybe earrings or piercings where they have to have, they can't have cheap metal earrings because it causes redness of their earlobe or wherever they're putting those piercings. The other is TB testing, the old TB testing where we actually inject a little antigen under your skin and you wait to see if you have a reaction and they check it somewhere about 2 days later. And that TB testing was kind of based off a delayed hypersensitivity reaction. So if you had TB, you would react to that antigen that they injected, but you would react for a few days. Now, let's talk real briefly about other types of reactions that are maybe less clear. One is transplant rejection. Now, transplant rejection, there's a couple different types of transplant rejection that can happen because if you think about it, transplants are foreign tissues that you're putting in a body, and so it's not uncommon to have hypersensitivity reactions to them. A hyperacute transplant rejection would be an immediate rejection. So if we put a kidney in someone and we put the kidney was the wrong blood type, that would be immediate. As soon as the surgeon put that kidney in, they would see a rejection of it. So they're actually not very common because we're a little bit more careful about that and we do a lot of good typing and crossing. But that would be a hyperacute, an immediate reaction. It would immediately reject that tissue. An acute transplant rejection is a rejection within the first few months. And so we do give patients high doses of anti-rejection medications to kind of calm down their immune system so that they ignore this foreign tissue that's been put in them. We use prednisone a lot to kind of settle that down and other type of transplant medications to lower the risk of this. But acute transplant rejection usually occurs within the first few months of transplant. Chronic transplant rejection is longer. It takes years and it's kind of a low level chronic inflammation. So, sometimes you put a kidney in and 10, 15 years, it goes bad. It's from maybe a chronic rejection. There's also something called graft versus host, and we see this after a bone marrow transplant or a stem cell transplant, where we give the host a new set of stem cells, that's the graft, and what can happen is the graft will actually start attacking the host if it takes over. In these particular cases, graft versus host disease is very complicated, very difficult to manage. It can be acute or it can be chronic, but the symptoms we see are very systemic and throughout the whole body because usually stem cells are reaching all parts of your body. So it's not like just rejecting a kidney and going into kidney failure. You're actually having whole body systemic reactions to it. Another thing I wanted to talk briefly about is latex allergies. Latex allergies can be type 1, causing anaphylaxis, which is very serious, or they can be type 4 dermatitis, where you just get kind of red skin and delayed hypersensitivity. Latex allergies can range from mild to severe, and exposure to latex can be from hands-on physical contact, inhalation, injection, or even surgical if you're using equipment that has latex during a surgery. So latex allergies can kind of fall into either a type 1 anaphylactic type of reaction or just the dermatitis. Last, let's talk about deficient immunity when you don't have enough immunity. So, all up until now, we've been talking about too much immune response. And now I want to talk about not enough immune response. So, not enough immune response is really going to what you're going to see is an increase in infections. And in not enough of immune response, you can have a deficiency of your innate immune system or of your adaptive immune system. So, it can be a problem in either the innate or the adaptive piece because you need them both. Deficient immunity can be primary, meaning it's some type of disease. That has attacked the immune system or a defect in the innate or the adaptive immune system. So, really, what you have is a disease that has attacked, or you have a lack of one of your immune systems. So acquired means it's something that you acquired or got. HIV is a good example of an acquired primary deficiency. Okay, HIV will attack your CD4 cells and kill them off. You can also be born with a bad immune system. Maybe you're born without B cells or T cells that aren't functioning well. And these both of these cases, that's a primary problem with your immune system not functioning because it's either missing a piece or a piece has died off or been attacked. Now, secondary immune deficiencies are related to another issue that if you resolved it, in theory, your immune system would bounce back. Very commonly, a secondary deficient immune problem would be something like chemotherapy that has lowered your immune response. And once you stop that chemotherapy, then your immune system would cycle back up. So, secondary is related to another disorder that has lowered your immune response. In both cases, primary, secondary, what you're going to see is an increase in infections, and patients are going to get infections more frequently. All right. And there you go. We've got our completed map here. So, thank you again for spending some time with me. I know you have some studying to do, so I'm going to let you go and get to that pathophysiology. Remember to like and subscribe to our station if you have enjoyed the video. Have a great day.